If you're 120 pounds and you have perfect health, why are you taking a GLP-1? You'll see celebrities taking it. You'll see people who clearly don't need to be taking it. And then they get like acute pancreatitis. Yeah, no shit. You didn't need it.
That was always the running joke in the house, is that the ladies in my family would grow the mustache and then have irregular menstrual cycle.
I talk about my experience with my clients who do have PCOS because it's important to acknowledge that you aren't alone in this.
So we're talking, everybody having a good week?
Yep.
Quick week. Got the new baby, and Ella, you got a big interview coming up too, right?
Oh yeah, I'm so excited. So I got a new interview for University of Really Dreaming of like perfect mentor, everything. I'm so excited.
When is that?
Nice. Well, congrats on that. Congrats.
It's going to be between the 17th and 21st, sometime around there. I'm receiving an email when the time is confirmed, but I got the invitation and I'm so excited.
Closing in.
Yes, finally. Mice versus humans, and it's so different. But it just goes to show how different humans and mice are. So.
Yeah, no, that's interesting stuff for sure. So yeah, I'm excited for you, and we'll be following along your journey. That's gonna be pretty cool to see. So, but yeah, so kind of jumping into the podcast today and the topics, we were talking about looking to do an episode a little bit more, closer to home. I think, Justin, I know you've coached and helped a lot of women with PCOS, and have some ladies, kind of close to you in life with that. Ella, I know you've shared your PCOS kind of experience and what that's like as well. So not only from the support system for people and kind of different educational resources that both you have the background, but also a lot of personal insights, I think, which is pretty exciting and unique, for a lot of people out there to kind of share that perspective. And so I thought, to kick it off, I want to get into some high level kind of questions, and then we'll kind of go more in depth as we progress through the discussion today. But I did think maybe if we started with you, Ella, to maybe just talk a little bit about, what is PCOS? How did you first learn of it? Anything that you could share from kind of your individual experience from there. And then maybe Justin will kind of, shift over to you, talking a little bit more about clients and such. So yeah, Ella, if you wouldn't mind kind of sharing a little bit of that, and we'll kind of see where it takes us.
Sure. So I was diagnosed with PCOS way back in or at least my doctors first thought I had PCOS back in 2017, I want to say. And it was the first time that I ever went to a gynecologist. And it was actually completely in secret. I went for contraception, and the doctor was trying to give me contraception, but I was not having regular periods at the time. So the doctor basically said, well, let me get an ultrasound. Let's see what's going on. They got an ultrasound. They saw a bunch of these little dots on my ovaries. And they said, well, it looks like you might have PCOS, but we just need to do a hormone panel to confirm it. I never ended up going back to that gynecologist. I ended up going to college in 2020. It was like 3 years before COVID. So by the time that I got around to doing it, everything was on lockdown. About a year and a half later, I went to the gynecologist in my area, which was now in Michigan, for some actual contraception again, because once again, I never ended up getting it. And when I did, they struggled because I was never on a regular cycle, so they could never time it properly. And so at the end of the day, what they did is they gave me a hormone panel. They found out that my testosterone was above range. My estrogen was completely crashed. My progesterone was completely crashed. Everything was all over the place. They took a look at my ultrasound again, this time, and more cysts. And this time the cyst was really big, and they were debating on whether or not I should have surgery or not. It ended up popping. Everything ended up being okay. But at the end of the day, I found out that I had PCOS. Fast forward to now, my current partner convinced me to try doing a bulk for the first time in my life. And when I did, I could not lose the weight for the life of me because it was the most difficult thing. I was starving all the time. It was horrible. So I bulked up and never could get back down. And then I had 3 surgeries and it was all over the place. Everything was a mess. But I guess lesson learned, I figured out that I had PCOS. So it's, and just to like, I guess to drive it home, my HbA1c is almost always 5.5 or higher. So it's never below that. Very recently, though, I've managed to get it down, which is really great. And I have managed to get my appetite under control, and I actually feel like a normal person. So that's pretty amazing. I guess that's about there.
I think it's. Oh, go ahead.
Go ahead, Justin.
It's interesting that yours was clear cut and dry. I've worked with a lot of women sometimes who may not have any of like the clear cut symptoms like the excess androgens or even insulin resistance, but they may still have cystic ovaries, and they bounce in between OBs for 10 years, something like that, and no one ever can really pinpoint it. So it can be frustrating for some women, I'm sure. I can empathize, obviously can't relate, but you have a lot of the symptoms, but you're not able to figure out what's going on. I think some women do, carry excess androgens if that's testosterone or adrenal hormones turning into testosterone, but not always are there clear-cut signs. And I feel like PCOS is almost like a spectrum because there's so many things that could cause cystic ovaries. And I think it's super interesting that each case seems to be unique. I do see the insulin resistance present a lot most of the time, or just low-grade inflammation, what can't be pinpointed exactly. And I was curious on, Ella, your thoughts. We were talking earlier before we started rolling, and some of the roles that insulin has at the ovaries, and potentially if those could be inflammatory processes present, maybe at a gene level that you couldn't pick up on blood work.
Yeah. So I guess the first part is like, at first it was not clear cut and dry. And I say that it sounds clear cut and dry when I look back on it. But when I like dive into like the very early stages, whenever I did ever have a cycle, because even though it's irregular, I do have a cycle. And usually when that cycle does come around, I have a little less cysts on my ovaries. I usually have my testosterone drops ever so slightly. So sometimes it'll be in range, but my estrogen will be super low. Everything will be super low. So I'll look quote unquote normal. But then as soon as like, let's say a few months pass by and I don't have any, like, I don't have my cycle, I don't have anything, you'll get an ultrasound on me and you'll see cysts all over my ovaries. And it's typically, at least that's what my gynecologist said, was that usually when your like cycle does come around, the cysts will, like the popped ones will start to be cleared out along with the blood. So it's it's clear cut and dry to an extent, like if you take it over time, but I feel like it's so difficult to get it in like that one doctor's appointment where, like, let's say that person didn't eat anything before their blood test and maybe they just haven't been eating that much sugar over the past month and their HbA1c is not as high as it would have been. So it's so difficult to like, because blood work is just like one point in time. It's not like the entire month's worth of blood work. So I make it sound like easy and like not difficult in terms of like how it got diagnosed, but it was so difficult to get it onto my what is it called, the my chart. Like it was so difficult to get it on my chart because the doctor refused to put it there for like the longest time because they only had an ultrasound, they only had my hormones, they never did both. So it was always so difficult. But putting that aside, from what I've read, insulin resistance at the ovaries seems to play a really big role in propagating the excess androgens as well as the insulin resistance part of PCOS, and may even play a role in the development of cysts. That being said, I don't know the exact genes responsible. It is multifactorial, definitely. And there's probably multiple genes involved, I could imagine. There was one that you mentioned earlier. I believe it was PGCM1, right?
PGRMC1. And I'm not an expert in that, but I was interested in it just because I really like to look at like origins and roles of hormones in the body. I'm a huge nerd, so I was doing that last Sunday. My son wasn't with me, so I sat for like 2 hours and I was reading that. My wife's like, "What are you doing?" I'm like, "You can go ahead and go to bed." Like, I never get a chance to sit and look over this, but yeah, I was looking at that gene and potentially its role in. They were talking anti-apoptotic effects of progesterone on granulosa cells. And basically, if you have a deficiency in this specific gene, you may experience like proliferation of tissue. Um, was one. It's kind of a theory that these doctors were talking about, and the other piece of that they were calling it endometrial deficiency. So I guess as you build your endometrium and you break down that sheath, when you start to bleed, some women have a deficiency in making that preparation, and that can also induce cysts because you're not able to build that sheath and then break it down. So I guess cells can replicate over time. Something that I was unfamiliar with. I always look more at hormones, but I was like, the gene level actually looks really interesting because there's so many gray areas that women have with PCOS. Is like, like what you're saying, you can't always pinpoint it. And I wish there was more sophisticated testings to kind of look deeper and see what's going on. I know like theca cells and granulosa cells play a big role in ovarian hormone signaling, and there seems to be a lot of disruption there. But I've worked with really good OBGYNs in a hormone setting, and I've seen her prescribe a lot of medications, but never really talk specifically at like gene level and what's going on at the ovary. So super interesting stuff.
Yeah, I mean, it definitely could be a possibility, at least for like the cyst development. Like if they're seeing excessive like cell growth, that makes sense. Specifically with PCOS, from what my gynecologist told me, is that PCOS, like the most principal characteristic that pretty much defines what PCOS is not just cysts, but lumpy, like little tiny dot like cysts all over the ovaries. So, a common misconception is that if you have like one or two cysts, you could have PCOS. That doesn't seem to be the case. It seems to be more so defined by the lumpiness of the cysts. And if you like, yes, sure, PCOS, like women with PCOS can have times where you don't have as many, but it'll primarily be that. Like, that's what defines PCOS. So, at least on that level, I would say it would make sense that on a gene level, you're talking about genes involved in cell growth, because that makes quite a bit of sense. And I would also assume that there's some that are involved in insulin, because that was something that I did a little bit more digging into, was where the ovaries would become insulin resistant. So then the pancreas would compensate and make more insulin. And as a response to that, you're causing hyperinsulinemia, which ends up causing whole body insulin resistance due to basically overstimulating every single insulin receptor that you're talking about. And then once you have that insulin resistance, you also have the excess androgens that come alongside the insulin resistant ovaries as well. So it's like a mixture of various things, and I thought it was kind of interesting how multifactorial it is.
Super multifactorial. The other interesting piece that I've listened to a lot of podcasts, and people talk about PCOS being almost an evolutionary thing, is women at one point needed insulin resistance to live. And so we could see like some of those genes being passed down through generations, because it's like, yeah, if we're hunters and gatherers and we don't know where our next meal is, to kind of have that insulin resistance, that's a pretty good thing to have. But in the day and age we're in now, all of us can reach in our cabinets and get food. So those genes, I think, could be more problematic just due to the overconsumption of food. It's specifically in the U.S., I would say we probably are notorious to overeat compared to other countries.
Oh my God. Have you heard of the epigenetic markers that were like associated with populations that had starvations and famines that occurred in the past? It is so interesting how that like happens, where like you'll have people who are like maybe in it's very grim, but like the people who were subjected to concentration camps, people who were subjected to extreme starvation, typically what will happen is the generation afterwards, when they're in more favorable times, or at least the generations afterwards. So like, let's say 1 or 2 generations go by, they're still in that extreme starvation, but then 1 year later, they're all out of it and they're fine. Typically that generation will become obese because in the generations prior, those people who were able to hold on to their body fat survived. Those who weren't did not. So it's like the epigenetics get passed down over time. It's so crazy how that works.
That's one thing I was going to ask too. Just, Justin and even yourself, Al, like when you, so let's ask both you and Ella, yours for yourself, or just maybe other, if you haven't, if you have coached or worked with other women, did you guys find that someone in their family also had PCOS, related to the gene thing? Because I seen kind of it seemed like there were some studies that said it could be, but then some were like there still needs to be more, that the typical line at the end of a study, like further research is still needed to confirm and blah blah blah. So I'm just curious if there's any anecdotal things out there, and maybe even like listeners out there or family members that maybe hear this of someone who has PCOS, what's the likelihood and or how does it apply to people you've interacted with? Have you noticed it seemed to be hereditary or connected?
Yeah. I guess I'll go first and then let Justin take over. I coached an entire family of people with PCOS, which was kind of interesting. Specifically, there was this one lovely lady. Her and her boyfriend were being coached by me and Jackson, and both of them were diagnosed with morbid obesity. And the girl that I was working with, the girlfriend, she had PCOS, and then her mother ended up working with me at one point, and she also had PCOS. So, or at least she thought she had PCOS. Her girlfriend was confirmed. Or sorry, daughter. Gee, dear Lord, it's so funny working with an entire family of people. But
Not get mixed up.
Yeah, but all of them had PCOS, or at least all the females that we worked with that one group of people had PCOS, and it was so interesting how it's like it can get passed down. I will say there's people in my family with diabetes, but not many people have PCOS for me.
Got it.
Yeah, I would say see it from the coaching standpoint. I think science and medicine has gotten better. So it's like, oh yeah, everybody in my family has irregular menstrual cycles. We all grow mustache, and that's not me being rude. It's just like, yeah, we always joke about it. And even my like direct family members, have experienced that. I've worked with my mom and sister, and even myself. We all have like low grade insulin resistance. My mom had gestational diabetes, when we were being developed. So we carry I run higher glucose, higher insulin. I have to be very cautious, and I do a lot of things to regulate that. But
I know that for the longest time that I felt I was very alone.
That was always the running joke in the house, is that the ladies in my family would grow the mustache and then have irregular menstrual cycles. So I do see that, and I've also seen it with clients as well. But it's more, I think, maybe never getting a diagnosis just because testing wasn't done as much. We have just so much at disposal now. 50 years ago, you couldn't buy a test and just go on your own whim and just
right.
look at things. So I really like where we're at in the time, because we have so much resources available, and we can really pinpoint things even just on our own. Cash paid services really make that easy.
Yeah, that's so interesting. And it's also so like, I feel like that's a really big part of PCOS that doesn't get talked about a lot, is the excess hair part. So I've had it as well, and it's not fun. It's really like, at least for us women, it's like having excess hair growth is not it. It's embarrassing, and it's something you don't want to admit to people. So it's so, yeah.
And do you find is that strictly tied to the testosterone production, or is there additional layer to that? I would imagine probably testosterone is the answer, but is there additional layer to that too? Do women with PCOS have a higher likelihood of converting to the active form, the alpha DHT pathway? Like is Is that prevalent in women with PCOS? Have you guys seen, or are you aware of that? I just kind of a curiosity.
I would say, yeah. Sometimes I think it depends. I think there's just so many things, so many ways hormones can metabolize, and I think some women may, instead of converting to testosterone, if we're looking at DHEA, make a lot of androstenedione, and then that's going to bifurcate, and then you can alpha or beta preference that. I do see when like insulin resistance is present, that alpha pathway does seem to be more prevalent. And even in men, if we're insulin resistant, we tend to 5-alpha reduce higher, or if we have inflammation present. The other piece, I think, is sex hormone binding globulin. If we have a very low amount of that, which is pretty common with insulin resistance or PCOS, I think that those DHT is more likely to attach to follicles where we don't want them. So if that's face or scalp, or outside of standard places, low back. So those are questions that I tend to ask. I do a lot of analysis of blood work for women, probably on a weekly basis, at least 5 or 6. I meet women and we'll walk through that process with them. And those are some of the questions I'll kind of screen for, because like to Ella's point, I don't think that's something a lot of people want to be forthcoming about. So it's like asking those questions the right way, and being able to gather trusted information to kind of figure out why they're having that excess androgen production, which could turn into hirsutism, whatever's going on. But to answer your question, yes, I definitely see that.
And also, I guess the beneficial side of things, even like, I know it sounds so strange saying beneficial in PCOS, but the beneficial part of PCOS that I found personally was once I got my insulin resistance under control, and I have gotten under control twice in my life. There was one time, it was around 2020, 2021. I was doing a lot of cardiovascular exercise. I managed to get it under control, and then I immediately like blew up in strength. Like my muscle growth was off the charts. I was really like, just to put in perspective, when I say that, like, my genetics were for strength to an extent, but then I literally grew like exponentially since then. And I feel like women with PCOS, yes, the hair growth is very embarrassing, and it's not something that many women will want to admit. But I feel like it's also important to talk about, like, acknowledging both like the positives and negatives of the condition, because it's a condition that's not going to be cured. Like, you can't cure PCOS. I hear that a lot with many fitness influencers online, and it's a dangerous thing to promote because you can't cure it. It's there. You're not going to get rid of it. No matter how insulin sensitive you make yourself, no matter how much you try to fix your hormones, you're still going to have PCOS, because it's, as you said, it's in your genes.
Right.
So,
yeah. And I had a couple follow-up questions on that. I mean, I think that the first one I have is related to testing, and then I would like to get into just kind of how you live with that, what you do, how to guide women with some protocols, maybe some under supervision, some that maybe they could walk away from this episode with some takeaways. But I am curious first on the testing front, and I'd like to go a little deeper on this, but to understand, like Ella and Justin, feel free to chime in after Ella's experience, but in the traditional medical setting, if you will, like, was it just, and I say just, but maybe that was enough, but was it blood testing was the main like a one-time snapshot? Was that the primary testing, or was there additional genetic testing, metabolites, cycle mapping, like looking at the whole month? I'm just curious to, like, what does that look like as far as the traditional provider that's is kind of treating someone out there? For yourself, Ella, like what did that look like?
Oh, I wasn't sure if you wanted Justin to go first.
Yep. My apologies. I didn't lead. I didn't lead the witness. I didn't lead the witness well enough. No.
All good. So the primary thing for me was, first, the fact that I had a irregular cycle. So when you don't have a period for 5 months and you're not pregnant, obviously there's something going on. Then after that, it was looking at my ultrasound. When they looked at my ultrasound and saw all the cysts, They're like, okay, yeah, you got PCOS. The hormone testing was more so just to reconfirm and validate what they were finding in the ultrasound and my literally like just not having a cycle. And that was pretty much that was about it. And then from there on, it was they gave me a patch every now and then just to give me a period, because if I don't have one, then that can cause osteoporosis and even some rare types of cancers. So it was always important to stay on top of it. But of course, having birth control every couple months is not fun. So I ended up just trying to get my insulin in check. And once I did, then I started having a little more regular periods to the point where my doctor was comfortable with me not having the patch.
Got it. Justin, how about you? What have you seen or experienced?
Yeah, I think it depends on what you're looking at. I think some of the more interesting things that was shown to me with the doctor I worked with was when we see excess adrenal hormones. So if we're doing, maybe more comprehensive testing, we see like elevations in DHEA in women. She would always look at something called 17-hydroxyprogesterone, which is an upstream metabolite. So we look at progesterone. There's some action at the gonad, but there's also a lot of action at the adrenal glands with progesterone and how it's made. So if we're looking at potentially where that excess of androgen is coming from, she would always look into 17-OH progesterone. We maybe look at androstenedione. Those are potentials to see where it's coming from. Outside of like standard testosterone, I don't really like looking at DHT on blood, but looking at it maybe dried urine seems a lot better because we get it over a 24-hour period, and we can see, again, how much we're preferring alpha metabolites to beta metabolites. And then I think, any woman with PCOS is just kind of ruling things out, especially if you haven't had a lot of answers or success traditionally, is looking at insulin, looking at glucose, looking at A1C. I think those are good ways. HSCRP, I think with insulin resistance, potentially inflammation processes are elevated. So looking at general inflammatory markers are a good rule of thumb if we're just trying to cross off potentially where is this excess androgen coming from. You kind of just work your way down that list. And that's why I like diagnostics. And when someone sits in front of me, I'm like, okay, we have these symptoms. Right. Let's cross off potentially why these maybe are not that. And then we just kind of rule things out. And I think that kind of makes it more digestible for someone, because if you're not a huge nerd and don't like to look at blood work, when you get 6 pages back and there's 56 markers, you're like, oh my goodness, this is overwhelming. To have somebody be able to kind of really work through it with you. And then I think you have to also take into account symptoms along with lab numbers. You can't just solely go off of numbers of like, hey, you're in range, there's nothing wrong with you, because I know a lot of people hear that as well. So you really have to take into account everything when you're looking at diagnostics.
Got it.
Yeah. Just wanted to add in, I would say I would look at A1C over insulin and glucose. That would be like the main thing that I would look over in terms of like insulin resistance. Because what I've noticed is my insulin and glucose are almost always quote unquote in range. It's just, and that's just on the basis that I usually go into like blood tests fasted. So it's not always the most, telling of it, but like when you look at A1C, it's like the past couple months of glucose control. And I guess for those out there who don't know what A1C is, it basically is when you glycate or you add a glucose molecule onto a protein called hemoglobin, which basically helps your blood cells transport oxygen around your body. So that's like the simple way of putting it is like if you want to think about it, you're caramelizing your blood cells. So if you have too much blood sugar, that's typically you'll see higher A1C levels.
You know what? I agree with you on that fasting piece. The OB I keep referring to, she would do a 5-point glucose tolerance test, and then she would map insulin with that. So she'd dextrose challenge you. Yeah. And then, so that's a long time in the lab, but she's like, yeah, you can't see your insulin looks normal. Your A1C is creeping up. Your glucose looks normal. Let's test your sugar and then let's test your insulin to see like how high, even if your blood sugar stays level, how high is your insulin going up to counter that? I always thought that was really interesting.
You want to know the gold standard for that though? It's this lovely test called the hyperinsulinemic euglycemic clamp. It's my favorite freaking test ever. It's so interesting. What they do is they have you with one arm with a fixed dose of insulin. So you have basically hyperinsulinemia in one arm, and then on the other arm you've got glucose, and the amount of glucose is fixed to euglycemic levels. So the more glucose that you have to put into the person's body, the more insulin sensitive they are, because the more their insulin receptors are responding to the insulin in the other arm. But on the flip side, if you only have to like put in like very little bit of glucose, that's telling of insulin resistance, because then on the other arm, if your insulin receptors aren't responding to the high hyperinsulinemic levels, then you have to put in very little glucose because you can't maintain euglycemia with higher glucose levels. So it's and euglycemia just means healthy glucose. So it's such an interesting test. Sorry, that's like my favorite thing on the.
No, I was gonna say I had a friend who, he might have been serious when he said this, because this is back a while ago, and he was like a mass monster in the bodybuilding world. He's kind of a mad scientist, but he actually said, he's like, there's a test, and he was referencing that, and he said, but I would like to add essential amino acids and some sodium and just sit there all day and just grow the whole day, like just let's go. I'm like, he's like, outside of my training sessions, just keep them both going the entire day. I was like, what? Anyways, now mind you, I'll admit this is also, I won't name his name because I can say this. We both did this though. So if he ever publicly says he didn't, he's a liar. But we would eat lunch walking without a jacket on in the winter because we were trying to diet down, and we just knew that our bodies would have to burn more calories just by being out and being in the cold. So how we didn't get pneumonia or something like we were dieting for a show, but that was the saying, in our 18 to when I competed between 18 and 23 years old, it was like, well, the guy who's closest to death wins. So, here we go. It's like,
oh man.
Yeah. Now, yeah, I can't even believe it. But that's where my brain went as you're explaining that. I was like, yes, I remember that. It's been a while, but I do remember that. So.
I've never heard of that test. Yeah, it's super. I mean, obviously, it's a very controlled setting, so you don't want to do that at home. But
yeah, no.
it's interesting.
It's such a cool test. I actually, so one of the old studies that I was helping out with, well, at least hopefully it becomes a study. I don't even know if they're going to publish this data, but we basically, so they took a bunch of type 2 diabetic, lean healthy young and lean healthy old individuals, and they put them into this hyperinsulinemic euglycemic clamp, and then they took biopsies from their muscle. And then what my job was to isolate RNA from those samples. And what they're doing is they're figuring out the differences. We don't know what's going to happen. We don't know the data. We don't know the answers, but it's a really great way to characterize insulin stimulation and like what insulin actually does in the body on a gene level. So it's, I really want to see a study come out on either like cachetic or polycystic ovarian patients with the hyperinsulinemic euglycemic clamp doing that. That would be so cool, because those two patient populations are known to have insulin resistance due to either skeletal muscle wasting, literal insulin resistance at the skeletal muscle level due to the ovarian insulin resistance. But it's so, I would kill to have data just to look at that, because that would be so cool. But yeah, it's interesting.
It related to that study, because I do want to hit another that treatment topic stuff in a moment, but I do want to pause because a lot of people hear, you see it online, or it was obviously really, really out there, during a certain pandemic that was going on, is the term like RNA. So I'm wondering if you could explain what that is and then maybe another layer of it for application. Like, what were you doing in that study? Because you mentioned you were looking at the RNA, I believe, in the muscle cells, I think you said. So just for those out there that are like, yeah, I kind of heard of that, like, that's cool, but like, what exactly does that mean?
Yeah, sure. So everybody knows, or at least I hope everybody knows, what DNA is. If you don't, it is basically the instruction manual that is in every single cell in your body. All of your cells have the same DNA, and your DNA is basically made when sperm meets egg. If you didn't have the birds and the bees talk, I'm sorry, you're learning it now.
Be another episode. No,
yeah.
yeah.
But everybody has the same DNA in their cells. However, in order for your brain cell to be a brain cell and your heart cell to be a heart cell, they have to talk differently. You need different things to be expressed in a brain cell. So different genes in your DNA must be expressed to present as a heart cell, to be able to beat like a heart cell. If it doesn't do that, then it's another cell in your body. So if you have like a skin cell, you need special genes to be expressed for it to be a skin cell. Now, the way that your DNA basically talks to the rest of the machinery inside of each cell in your body is through molecules called messenger RNA. And if you want to think about it like a restaurant chain almost, where you've got the head honcho and they're like the owner of Chick-fil-A, every single franchise in the country. And that's your DNA. Now, your DNA is the head honcho, but he speaks an entirely different language from everybody else. Every other franchise speaks a different language. So the only way for the head honcho to communicate with them is to send these molecules called mRNA, which can be translated by another. Let's say your translator in your cell is your ribosome, which is a special little protein or RNA and protein enzyme, which basically translates that message. So just to kind of put things together, for your cells to communicate to communicate with themselves, it needs this molecule to be able to express as what it is. If it doesn't do this, then your skin cell becomes a heart cell, your heart cell becomes a brain cell. And this is actually how cancer occurs, because you're having different things be expressed when they shouldn't be. So, for example, your immune cells, in order for them to attack pathogens and foreign bodies, they need to be able to squeeze between other tissues and cells. That's a process called migration. Now, what happens when your skin cell is able to migrate to your brain? That's called cancer. So it's this interesting like regulation process of how your body like has the same code, has the same instructions, but they're just read off in different orders to become different things. And that the reading off in different orders part is what messenger RNA is. And RNA is basically that it's a copy of your DNA that can tell the cell what to be.
Yeah. No, that makes sense. Thanks for that. No, I appreciate that. So going back to the, PCOS, so person has PCOS, what is out there relative to, I guess we could start from like I'll label these treatments, overarching, call them all treatments. We'll say lifestyle could be one, nutrition could be another. I think supplementation be another, and maybe pharmacology be the fourth. So if we had like those four buckets, and maybe one of them's there's nothing, but what would you say are some things people could do in kind of each of those categories potentially, or a combination of all the above? Obviously, some of them would require definitely a clinician's engagement there, but just kind of curious to what can people do out there once if they think they have it, obviously go get tested and such, but maybe some things they could start doing, or potentially if they do have it, but they feel like they're not getting the answers and they want to take a little more action themselves.
Justin, you want to go first?
Yeah, I think depending on what we're looking at from areas of concern as far as insulin resistance or androgen excess, I would say a good rule of thumb for looking at like lifestyle movement probably is up there. I think everybody should do some resistance training. I don't really think the age matters. Not everybody needs to be deadlifting, but you could go push and pull on some machines. You can do some knee flexion and maybe a hip hinge if you're able to get in those positions. But like I think resistance training is kind of at the top if we're looking at being able to uptake glucose into the cell. Resistance training seems to be a really good thing to make that happen. So I would start there. Eating less food as a whole, whatever that means to that person. I think most of us can tend to overeat. I know I'm pretty meticulous with my food, and last night I ate a lot of sushi and I shouldn't have. So I think everybody
but
can.
Sushi's amazing though. You have to do that.
Yeah, we went crazy last night. Had too much of that. So I think, and then let's I don't really think processed food is like everybody now is like processed food is terrible for you. Everything in moderation. Like I have a little bit of processed food almost every day, but it's like 10% of my diet. I'm not worried about that 10%. I would start there. Ella, what do you think? What would you recommend?
Yeah, I definitely would recommend the exercise part. On like the mechanistic level, when we're talking about it, exercise helps the, or at least specifically resistance training exercise. You're talking about adapting or stimulating adaptations to the glycolytic fibers, the fibers that actually use glucose.
Right.
So if you're helping them like get better at using glucose, that's a great thing. And I mean, as that one really famous study said a while ago, and I could send it over. It's the DeFranzo Lilly lecture article. Skeletal muscle is literally the primary cause of insulin resistance or whole body insulin resistance. So it's the primary contributor. It takes up so much glucose. From what I've heard, it's like 80 to 90% based on those euglycemic hyperinsulinemic clamp studies. So the amount of glucose your skeletal muscle can take up, exercise is incredible for that.
Mm.
Um, on the diet side, I would basically recommend the same thing. I would just add on like fiber, maybe limit your cholesterol and saturated fat because those things, intracellular fat and like cholesterol, specifically the diacylglycerol mediated insulin resistance is like the two mechanisms of like how it occurs in your skeletal muscle. So I would just put like limitations on like excess saturated fat, basically the dietary guidelines, which is increase fiber, lower saturated fat. And then for processed foods, I would just like specify like it depends on the processed food. Like if you're eating protein bars, I don't think that's a problem. Like I feel like protein bars and protein powder is a fine processed food. It's like look at the nutrition label. If it's like half of it's added sugar and half of it's lard, maybe avoid it.
Yeah, makes sense. Anything, kind of transitioning over to supplementation, we don't want people to run out and just start randomly, buying supplements. But if there was a case where we're working with someone, maybe some, obviously specific circumstances, what are there maybe some supplements out there, if any, that you see that could be applicable, or maybe either of you have used? I don't know, Justin, if you want to take it first. What's out there? What could people potentially investigate?
Yeah, I think berberine seems to be interesting. I think that if we're looking at like entry level things of implementing in, if your digestive tract can handle it. I know some people can't really take berberine, but I would say that's kind of up there with things to help with glucose disposal. So I believe if I'm recalling this right, berberine is not going to have much action on gluconeogenesis like a metformin would, but it's going to help uptake glucose into muscle cell. So I would say that is up there. Chromium seems to be really interesting. I believe chromium was really high um, in our grains at one point in time. I believe there's less of that now just due to wheat where it's at standpoints of being genetically modified. I could be wrong on that, but pretty sure there's less chromium. So those two things will help with blood sugar control to a degree. And then if we're looking at inflammatory pieces there, turmeric, curcumin, omega-3 fatty acids seem to do really well. Kind of like the basic vitamins and minerals that people should be consuming, I think will tend to help a lot of those processes. But if we're looking at blood sugar control and we're looking at just like, hey, you can buy this over the counter, berberine is probably up there in my opinion. What do you think, Ella?
I would pretty much agree with that. Like, if you can go with berberine, I haven't really done much research onto those things. I take a really conservative approach when it comes to supplementation. So, for me, it would be more so like if you have a fiber supplement that you really like, or if you can incorporate. Like, I make these really high fiber pancakes because they're really good, and I have a really bad sweet tooth, so I like if I can incorporate fiber into something, then I'm going to do that. So like fiber supplementation, protein supplementation is really good, especially when we're talking about glucose control, because like if you can lower the glycemic index of foods, that's great. And so like then that and maybe like creatine, because that can improve like energy utilization of those like faster glycolytic fibers that are going to actually improve your insulin resistance. So creatine, protein, fiber, and then if you're deficient in a vitamin or mineral, then that's obviously going to help you, because like if you're not eating enough, then yes, take vitamin D.
Yeah, I don't want to get too far off on a tangent, but it's just so interesting because I remember, gosh, I want to say it was the late 90s when creatine was really coming on the sports scene, and like just to see, you know, they're studying it in different, you know, brain type cognitive issues and functions, you know, just it just, the application is in so many different places that when I talk to a lot of even men, but men and women that are on more aggressive weight loss protocols, I'm like, well, we can, you know, add, you know, this is something to consider, like, again, just depending on their goals, where they're deficient, etc., and just trying to explaining some of the utility it has and ways it can help not only with energy, but as you just mentioned, like just the effects it has on the muscle, the brain, etc. It's just the glycolytic, I can't even say the word, glycolytic fibers, as you were mentioning, like just those type of things. I think it's so associated in the bodybuilding world that a lot of people thought that, because I actually had a guy tell me that too. He's like, I thought this was like put on weight. I'm like, I mean, yes and no. It's going to take the crappy, not, this is not an exact scientific statement, but generally for an analogy for a person who just made that statement, I would use something like, well, picture all this like inflammation and fluid you have that you is not good, that you don't want, and let's say we took all that and crammed it in your muscles, and instead of your muscle being like a piece of beef jerky, it's like a nice juicy steak now. Like, what do you think has a little more ability to perform at a higher level? He's like, okay, cool. I'm like, yeah, it's not gonna make you fat, dude. It's cool. So that's a good thing to point.
I love that analogy so much. The beef jerky into a steak, because it literally is like that. It draws water into your muscles. So that's a fantastic analogy.
Yeah, I think people associate it with it being bloated and, you know, water retentive. And I'm like, well, yeah, like intracellular fluid, like if we're looking at performance, it probably has pretty good place in there. And we're probably, if you're eating enough protein, you know, if you are doing that, which most Americans don't,
Right.
probably are getting a good amount of creatine. I still supplement creatine on top of it because I do think from the performance aspects of going to the gym, that's an easy leverage for anybody just getting into weightlifting, you know?
Yeah, and I'll also say, like, even though we can get creatine from our diets, I feel like it's a little bit of a long shot to say that unless you're a really large man eating a lot of steak, it is very difficult to get that much creatine, at least the amount that's been demonstrated in the literature to have like the most peak optimal performance enhancing benefits. So as far as like for me as a 127-pound female,
Right.
it definitely makes sense, especially if I'm trying to keep my saturated fat a little bit lower. It helps a lot, especially for that. Other than that, I would also say if you are really insulin resistant and you have the option to go for a GLP-1, I've been doing a little from what you've sent me. It looks promising for PCOS, and they likely will come out with more research for that.
Yeah, I was going to mention that, just kind of getting into the pharmacology. I mean, I've seen some research related to GLP-1s. I think it was because the research prior to GLP-1s being so popular was the application of metformin was used in PCOS patients. So that's kind of why I was curious if you were seeing the literature out there as far as some of those, you know, treatments out there that are maybe used in other ways. I know for sleep apnea and obese patients, the GLP-1s are just approved for that by the FDA. It seems to, you know, I'm not an expert in this area and regulation and things, but it just seemed that like there's several recent studies, relatively recent, I guess, that popped up when I was kind of doing a little digging on the topic that, you know, if I'm, you know, the people making that and I am funding, you know, where to put it in, I'm going to want to put it into where the most bang for the buck. And it seems like it could be a population that it could be applicable to, you know. So is there any other treatments out there, or even any other anecdotes or kind of layers of information you want to add to the discussion on either metformin or GLP-1 used in PCOS? Is that, you know, and what are either of your opinions or thoughts on other medicated treatments or those? Maybe Justin, if we want to start with you.
Yeah, I think metformin, most definitely, from the gluconeogenesis standpoint, the anti-inflammatory standpoint, And I believe there is data supporting metformin due to insulin resistance at the ovary will reduce LH signaling. So if we look at the excess androgen piece of that, LH tends to go up, and that's where we're having continuous signaling to produce androgens. And then FSH may be less responsive, so we're not converting those androgens through aromatase at the ovary to make estrogen, because estrogen should be not disproportionately, but it should be higher than your testosterone as a woman for sure. Depending on where you are in the month, but I would say a good rule of thumb, if people want to get granular, more times than not, your estrogen will be a little bit higher. We tend to see less of that happening, so metformin does a really good job of that. I take metformin. I have for years. At the beginning of the podcast, we were talking about my family component of insulin resistance. So I really like that. It has a lot of other benefits from the microbiota. The other thing that I've been taking recently is low-dose naltrexone. It's anti-inflammatory. It's used for opioid recovery at like higher dosings or opioid withdrawal. But you could actually use it at a much lower dosing. The thing I find most interesting with low-dose naltrexone is it actually raises adiponectin, which is a protein hormone that's released in fat. When you have low levels of adiponectin, potentially higher levels of insulin resistance, inflammatory processes, endothelial dysfunction. So that seems to be very helpful of raising that. If we look at adipokines, I believe is the term for that. So direct interaction with fat cell. And then in the weight loss community, a lot of people like the low-dose naltrexone for appetite suppression. I don't really see that personally, but I do see the other things of modulating immune function, inflammation, and anecdotally, because I also think that matters, a better body composition is something that I've noticed as I've used it, because I've been taking it consistently every night for several months. And then GLP-1s, I think those are kind of like, there's so much not misinformation, I think misuse with GLP-1s. And I just think the evolution of those drugs, several years ago, we had more disposal of like the maybe second generation exenatide. It was a daily injection. It was like a 24-hour. I had seen people lose significant amount of weight doing that. And then this semaglutide came out, that amplified, because if we're looking at native GLP-1, I believe is very short-lived as this kind of extends. So we're having longer durations of slower digestion, I believe, is what we're looking at, like incretin hormones. And then we get into the tirzepatide, and then we have the dual agonists, where I think that is super promising from like an insulin resistance standpoint. I've not taken retatrutide yet, but something that I was probably going to be using next time I compete, because the triple agonist looks really interesting. So those are kind of like, if we're looking at pharmacology, those are the things that I really like to use and I have used personally and seen a lot of success with.
So just to quickly brief onto the GLP-1s, because that's where I've been doing a lot of research, at least into lately. So GLP-1 receptors for PCOS specifically. GLP-1 receptors are present on the ovary, specifically on granulosa cells within the follicles. So they definitely could have some really positive effects. And from what we've seen in the research, they do have positive effects on specifically improving ovarian function in women with PCOS. And we've even seen that GLP-1s have such a good effect on fertility in women that pregnancy rates have skyrocketed in the population, which is so, like, people who are on birth control, their birth control will fail when they're on GLP-1s. There was a case study that I saw that was specifically on this. So I thought that was really interesting, how it's got such a beneficial impact on fertility, at least for women in general, that even in women with PCOS who are their fertility is compromised, that it works. So it's kind of cool. But also something if you can't go that route, caffeine can also increase production of GLP-1. So if you have PCOS, I've wanted to mention this as well. caffeine might help you. And then as far as as GLP-1s progress, like I think it's very fascinating how we went from something that only lasts like a day to something that lasts a week. And now soon we're going to have other, like there's this new one that's coming out. It's called Maritide that not just is a GLP-1 agonist, but also a GIP antagonist, which I think is even very fascinating because because GIP-1 agonism shouldn't theoretically work because GIP-1 agonism doesn't have a direct effect on weight loss. In fact, I'm pretty sure it actually agonizes either lipogenesis or antagonizes like the process of lipolysis. So you're actually looking at something that should have a negative impact on weight loss, but apparently it has a good impact. So it's very interesting in that sense. But Maritide has GIP-1 antagonism, so it would directly impact, theoretically, weight loss outcomes. So that's, I guess, another interesting one coming out. But as far as like GLP-1s go, I have tried one and I got my period in like a day. So that's kind of after not having it for like 6 months. So that's kind of fascinating.
Yeah, it's interesting that interplay between the, insulin resistance or, the issues related to that and seeing that it seemed like in some of the studies that I was referencing or looking at before, it seemed to kind of give some pretty quick progress, if you will, if that's the best way to say it, in a lot of people. I mean, their application, like I said, that's where a clinician can come in that's prescribing those treatments and such, but it's still interesting to talk about that and just to kind of see, like I said, the multiple applications of that. But Justin, were you going to mention something on that note or a different topic?
Yeah, I would just say in general, like I've had people reach out and ask me about GLP-1s, and I just see like the pronounced anti-inflammatory effects that they have. So I think that carries over to cardiac tissue. I've seen several studies kind of citing, not necessarily. Somebody asked me, "Hey, have you heard anything about GLP-1 shrinking the size of the heart?" And I was like, "No, not that specifically, but improving or reducing inflammation at cardiac tissue." Which in turn helps with cardiac health. Again, like endothelial dysfunction, if we're looking at root causes of things, and inflammation and hardening of arteries seems to be very promising, and just reducing inflammation. I've seen people with Hashimoto's thyroiditis have less inflammatory issues when using a GLP-1. So again, taking all that into account, using them responsibly, eating enough protein, taking your creatine, doing resistance training. I think you need all of those things together. So you're not having, the negative side effects everybody talks about. There's so much fear mongering on social media, and it just drives me crazy because I'm like, how does this guy have 50,000 views on this video? The Gila Monster guy, have y'all seen that video where he's talking about you will develop medullary thyroid cancer? I was like, well, you can't take it if you have medullary thyroid cancer. And I've seen a prescriber give GLP-1s probably to 1,000 people. I know people have medullary thyroid cancer or multiple endocrine neoplasia. I just personally have not seen that. And I've worked in like broad settings with lots of people where these are prescribed. So I hate the fear mongering around GLP-1s.
I also think people need to realize you need to take it, or it's not something that you take if you don't need it. Like they do these studies on people with insulin resistance,
right,
which, by the way, PCOS, most women with PCOS do have insulin resistance. So when I say like women with PCOS, I'm talking about people like me who their HbA1c, despite being like lean, I usually have an HbA1c about pre-diabetic. So it makes sense for me to like be on something that helps me with insulin resistance. That being said, if you don't have that, don't take it. Like if you're 120 pounds and you have perfect health, why are you taking a GLP-1? And that's you'll see celebrities taking it. You'll see people who clearly don't need to be taking it. And then they get like acute pancreatitis. Yeah, no shit. You didn't need it.
There was another lady I seen on social media, and she's like, oh, it causes bone loss. Well, she developed amenorrhea because she'd quit eating and she got down to such a low weight. And I was like, you see that with athletes who don't have a cycle, who are not even using GLP-1s just because they're at such a low body weight and go prolonged period without menstrual cycle. I mean, that is, osteoporosis can definitely happen. Bone loss can happen at that point. Estrogen is important to, help keep bone together, if you will. So I just think, to Ella's point, it's like, if you don't need it, you don't take it. And, I think that you can definitely use them. You need to be responsible with them. I personally have not seen any muscle loss. I used it to get ready for a bodybuilding show, and this was the biggest I've ever been, the leanest I've ever been. So people saying like, hey, you're going to burn all your muscle by using GLP-1s, I don't really think that makes sense.
And also, just on that note, from what I've seen, GLP-1 agonism actually does increase muscle protein synthesis. So to everybody saying that it's going to cause sarcopenia, if you are sitting there lying on your bed and just chilling, you're not doing nothing, yeah, it's going to cause sarcopenia. If you actually do something, it's not going to cause sarcopenia. So it's first important to acknowledge the limitations of medication. Medications are used, they're prescribed by a doctor. Please talk to a doctor. Don't take them if you don't need them. They are studied in specific populations for a reason. It's so frustrating to see people who they'll take a medication when they don't need it, and then they'll complain about its side effects. Don't take it in the first place.
Well, I think I am looking forward to some future content on. I've been getting a lot of questions about, and I'm sure both of you would be interested in I hope you would help me create this content, but about how to read a study and how to look at the population groups and just how to skim one in 60 seconds or less or 90, whatever it is, high level, just how to look at stuff. Because I was talking about a podcast I was on, and we were talking about our favorite topic from a few episodes ago, which was testosterone supplements. And so I was just referencing, one population group was 86. I'm being a little dramatic, but 86-year-old women increase their testosterone by 200%. I'm like, look at the people in the group that had increased it. But there is one more point I did want to hit home, and it's the mental health piece related to women with PCOS, because I do, hope if someone is listening to this and they know someone that may have it, or they know that they have it, and I just like to unpack it a little bit. So I'll kind of frame this up and then get both of your input on it, either anecdotal, personal, or clinical literature, et cetera, of what you've seen. But one of the things it talks a lot about is a combination of factors that it's related to, which is the low progesterone that can come from PCOS, which is, and the insulin resistance and inflammatory markers causing some of those neurotransmitters to be off, like your dopamine, serotonin, things related to, obviously if progesterone is really low, and in some cases it can cause, or in many cases it's more of to put it plainly, it's more like a relaxant, right? So it can cause elevation and anxiety and those types of kind of feelings and things. And so I think on the mental health piece is another reason, for people to address it and to kind of press into getting the answers that they're looking for, but also for those maybe that are in relation with those people or supporting them and know them. And I'm just curious if you guys have anything to add on the effects that, PCOS can have related to mental health. I think we did talk a little bit about hair earlier. Obviously it's going to affect self-esteem and confidence, but I also think there's an interplay too, as far as those hormone irregularities are happening in the body that could lead to increased likelihood of anxiety disorders, depression, things of that nature. Just curious if you guys have anything to add to those topics.
I definitely do. So when I was in middle school, I used to grow I literally used to have some hair that grew over my mustache area and also by my eyebrows. And it was, I got bullied for it quite a bit. Middle school through high school, there was a few times where people would mention it and it was very embarrassing for me. And I remember there was one point where somebody would tease me so hard about it and literally very, very publicly in the middle of the classroom and stuff, to the point where I literally scratched the middle of my eyebrow until it bled, because I thought that scarring the area would prevent hair from growing there anymore. And I feel like it could be such a problem, especially with women with probably even worse side effects, because I grew up around parents that were very health conscious. They for me, people say that they binged on cupcakes. I binged on granola. So Like I was the kind of person who would eat a bag of almonds because it was the only thing in my house.
Sure.
But that being said, it's like still I grew up chubby. I grew up with like a couple of like a good I like back when I was in middle school and it was like all still like happening, I was 175 pounds. So it wasn't like I didn't start all the way up here. I was not in the best place. And it can really do something to you, especially when you do have trouble losing weight. It can be damaging because it's so easy to fall into like the trap of keto. I fell into the trap of intermittent fasting and
Mm.
it screwed up my mental health. I ended up falling into an ED, or am I allowed to say eating disorder on here? I'm not sure. Okay. So I fell into a really severe eating disorder for over 10 years. I still struggle with the mentality because it's like once you flip on the switch of an eating disorder, it never turns back off.
Mm.
And it sucks to have that. It's almost like it's already in you and it just takes a while to grow because once you get there and you are overweight, it's difficult to lose weight when you're insulin resistant. It's difficult to feel confident about yourself when you're growing hair in every freaking orifice. So
Mhm.
it's even if there's not a study on it, and I'm sure there's like very little literature on like the specific topic of women with PCOS and like maybe eating disorders or growing hair and their mental health outcomes. Like I'm sure there's a study on it, but it's probably not as well routed out as it should be. I can say from firsthand experience, it sucks.
Yeah. Yeah. No, I appreciate you sharing that. That's why I kind of wanted to bring that up is um, all the factors, not only the chemical factors internally, but the external factors, right? Like as things are coming up, you mentioned bullying, you mentioned, a lot of things that, you frankly just don't really have the control over. And I think it's important for people out there to acknowledge those things. And then it's maybe even an extra layer, not that it was needed, but an extra layer to kind of seek some help, figure out, what can I do to kind of help this, but not to forget the human part of it and just kind of supporting the person from a mental standpoint. Justin, how about you? You do a lot of like consultative things with women out there. Obviously you link up with physicians, and then you do some coaching. I'm sure, they're sharing a lot of things related to that. What are you seeing, or any commentary on that?
I would say Ella kind of hit it on the head. I think what I would say as a whole is not being discouraged. People are watching this, is like continue to work through that process. And I think the other piece, even as a man, I don't think it's talked a lot about eating disorders. I most definitely have an eating disorder, have my whole life. So I think one, having healthy outlets for those things is an important piece. And then, your self-worth is not directly correlated to your image. And I think a lot of what we look at in today's society with social media, so many people bank on that. And I really truly believe that, the internals matter so much more, and not even from a health aspect. I think from an emotional standpoint, I think that type of maturity matters a whole lot. If we're looking at things, going a little bit further, as far as like mental health, and you were bringing up some of like the hormones like progesterone. Progesterone is low, which it tends to be, especially with cystic ovaries, is like, potentially you're losing some like GABAergic effects. And depending on how you metabolize progesterone, it alpha or betas, just like your other hormones. And
Mm.
preferring that alpha pathway does have more of a parasympathetic effect. So some women do notice the anxiolytic benefits of progesterone. But, I would say, like, going back to what we were talking about before that, is continue to work through your process. And I do believe that you can't cure certain things, but you can definitely maintain and progress through that. I think with like the right team behind you, support systems, those things become a lot more manageable, and you can chunk them down over time, and get to a place where you want to be. And that looks different for all of us. Um, I would say that I've worked with a lot of women with PCOS, and I think getting their mindset right, I think the body follows that. The hardest thing is you can always move your body. I think getting your mind to cooperate with the body is always hard. So I'm really big into like coaching, but more of the mental aspect of it. Really being not even a cheerleader, just being someone to ration with. And I think those types of things over time, those compound, and then the physical definitely follows the mental. So that's what I'm after with coaching and working with women. So long-winded, but that's my thoughts around it.
I feel like it's like you coach the person, you don't coach the condition. So it's so important. It's like the reason why I went into like all the depth about at least like even though it's not necessarily the most quote unquote scientific thing in the world, I talk about my experience with my clients who do have PCOS because it's important to acknowledge that you aren't alone in this, and everybody is their own person and everybody's going to have their own specific experience with PCOS. I know that for the longest time that I felt I was very alone, and it made dealing with the eating disorder I had really difficult. So it's I hope that the people who listen to this take away that they aren't alone, and that when they do like ask for help, that they are being heard. And it's just like I feel like the most damaging part to helping people with PCOS is social media. Like the social media, like, oh yeah, you can cure PCOS if you go carnivore. That's the most harmful thing that somebody with PCOS can hear, because you can't cure PCOS. I'll say that right off the bat, that it's not curable, but we can help you get through and live your best life. And that's
Sure.
the biggest thing you can do for a person, is help them live their best life.
Yeah, no, I appreciate that. Those are, just, I think great notes to kind of wrap up the episode on. I think it's important for people out there, as you guys both have, articulated so well, just never give up. Like, just keep working through it. There are people out there that can help you with these things. There are reliable resources. And again, you're probably going to get distracted, regardless of whether it's PCOS related or other things you're trying to treat and get after, because we live in, the technological age, which is also like the informational age, right? And you're going to get some maybe intended misinformation because it's more clickbaity and they're trying to drive traffic. Maybe some, I don't know people's motives, but maybe some that is unintentional. And through that, there is some good content and some people that, are there to help, and they put their time into that. And obviously both of you, being very close to home, I think would fall into that category. So thanks so much, guys, again for, joining me in this episode and sharing this content with our viewers. And we'll definitely be sure to link different resources, research articles, some things that we talked about that maybe are a little more technical. If you want to nerd out on it, we'll have that for you, for the listeners out there as well, in our show notes and descriptions. And with that, I think we'll wrap. So any other closing thoughts, or are we just signing off?
Good talk. Yeah, I really enjoyed this. It's always fun to get granular, and I love Ella's background, as she can get super nerdy with me, which a lot of people don't like to do that. So I really enjoyed this episode.
I always enjoy having these episodes. I feel like they're very, very fun and relaxing to do. And I feel like the message of the episode is very good too. So it's very nice to kind of nerd out about PCOS for a little bit. I hope that I made sense when I was talking about RNA.
Yeah, it was great. All right. Well, with that, we'll see you guys. Take care.